And I would like to thank everyone for joining our Implementation Research Group Cyber Seminar today. My name is Christine Kowalski, and I'm an implementation scientist and the director of the Implementation Research Group. That group is a learning collaborative set up for sharing best practices and lessons learned in implementation science. We have over 500 members in the group, and the session today is part of our monthly catalog of events. If you just happen to join this session today and you're not part of the IRG and you would like to join the group, you can send an email to irg@va.gov. And in just a moment, I'll put that email address in the chat too. Sometimes we get questions about that. But now I'd like to thank our presenter for his work in preparing for the session today. Dr. Christopher Miller is a clinical psychologist and investigator at the VA Boston Healthcare System Center for Healthcare Organization and Implementation Research, known as QUERI. He also has an appointment as an assistant professor of psychology in the Harvard Medical School Department of Psychiatry, and he is a co-PI of the VA Behavioral Health QUERI. His research focuses primarily on the implementation of team-based outpatient mental health care. And in the field of implementation science and within QUERI, we have lately been focusing a lot on implementation strategies. And as we all know, those strategies are used to enhance the uptake of evidence-based practices in routine clinical care. And like the practices themselves, implementation strategies are frequently modified. And so in this session, Dr. Miller will be presenting the FRAME-IS, which is a framework that can be used for documenting modifications to implementation strategies. So thank you all again for joining. Please enjoy the session. And now I will turn things over to Dr. Miller.
Thank you for that wonderful introduction, Christine. Am I coming through okay on the audio?
Yes, you are. We can hear you great.
Okay.
Thank you.
Great. Well, I will dive right in then. Thank you, everybody, for being here. As was mentioned before, the primary focus here is going to be on this framework, the FRAME-IS. But let me just make sure I can advance the slides effectively. There we go. So here's an outline of what I'll be talking about today. I will start, as with many VA talks, with acknowledgments and disclaimers. I'll set the stage with some definitions as well as why we think this field of study is important. I'll talk a little bit about the development of the FRAME-IS and the components of the FRAME-IS. We'll also briefly talk through an example of how the FRAME-IS has been used to kind of document modifications to implementation strategies in the past. And then we'll talk about future directions and wrap up. So first, in terms of acknowledgments, the views that we're presenting today are our own. We don't have any conflicts of interest to declare. As with a lot of this field, I think if we wanted to make a lot of money off of our research, then probably the nitty-gritty details of implementation frameworks probably wouldn't be where we should have gone. If you have one takeaway from the session today, hopefully it's to check out the associated paper, which is out in Implementation Science. It is available open access. I want to really thank the co-authors on this and other works that we've done kind of in this field. And also some details follow on those who weighed in to really lead us to the final version of the FRAME-IS, including many people from the Implementation Research Group. In terms of funding support, we've got a lot here. I won't belabor the specific funding details, except probably to shout out the Implementation Research Institute, or IRI. All of us co-authors have been involved with IRI in one way, shape, or form over the last decade. So again, here's the screenshot of the front kind of title piece of the manuscript, again, in Implementation Science. So with that out of the way, I wanted to talk about just a few brief definitions here. I think a lot of folks on this call are probably familiar with these, but really this is a part of the field where there are many kind of competing definitions or different use of verbiage throughout. So for our purposes today, I'll be using EBP, or evidence-based practice, to refer to a clinical intervention that we've got some evidence is effective in some way, shape, or form. A lot of different examples listed here. For those of you who've read Jeff Curran's piece on kind of oversimplifying implementation science principles, the EBP is the thing that we want to get people to use more frequently. In contrast, implementation strategies, which we'll be focusing on today, are the methods or techniques used to enhance the uptake or increase the use of a given EBP, right? So again, in Jeff Curran's words, these implementation strategies, the stuff we do to try to help people or places do the thing, All right. Now, we know in practice that oftentimes there can be some blurred lines between EBPs and the implementation strategies used to get them into practice. For example, as with a psychotherapy manual that includes some components about how to make sure people are using it effectively. But for our purposes, we want to keep this distinction in mind, and some citations on the bottom for further details as well. Other definitions, we are going to use the term modification to refer to any changes, be they proactive or reactive, made to an intervention or program. That is, the term modification here can refer to EBPs or the implementation strategies used to get them into practice. And we use the term adaptation to refer to the subset of modifications that are made in a planned or proactive manner, right? So somebody may, for example, modify their delivery of an evidence-based psychotherapy if a patient shows up 30 minutes late to a 45-minute appointment. That would be considered likely an unplanned modification. In contrast, if you developed a version of that psychotherapy manual that's meant to be delivered in 15-minute bites, then that would be an adaptation or a planned change, even though the content of those two things would be the same. What differentiates these is the level of planfulness or kind of upfrontedness that goes into the modification itself. So with that in mind, let's talk about why we care about this stuff, right? So when you think about modifications, some of you may have seen this slide before in other versions of these kind of talks that we've given, but you know, the traditional clinical trials view of modifications, especially the evidence-based practices, is that you really want to avoid them because they threaten the internal validity of your study, right? If the EBP is delivered in a different way by every clinician in your trial, then it's hard to tell at the end of the day which version of that EBP was actually the effective one, even if you find overall good results from that study. Perhaps a more realist view acknowledges that modifications are basically inevitable, so we might as well document them just so we know what's going on. But really the view that we take here is that modifications, be they to EBPs or the implementation strategies, are essential to maximize EBP success and to reduce health disparities, especially in a situation where the kind of unmodified EBP, for example, might be really geared toward populations that are not the underserved populations who may be most in need of help, right? So I want to acknowledge here some work by Dr. Bauman and Leo Cavassa that really we think that developing the science of adaptations may be seen as one of the 5 key elements to really address inequities or health disparities. I apologize for the coloring here, but for those of you who have the slide set separate from this presentation mode, hopefully you can click on that link to go right to the article. All right. So we don't just think that modifications or adaptations are common, although they are. We think that they are essential in many situations, right? But without measurement, there is no study, and without study, there is no improvement, right? So answering questions like when, where, how, why, and by whom should modifications be made, at the very least, to address this, you need to engage in some documentation so we know what's happened. The screenshot here is of probably a well-known article for this group, but David Chambers and Wynne Norton's Adaptome, basically acknowledging that what we really would like to do, the holy grail for the adaptation literature, is to develop some kind of compendium where we carefully note what kind of adaptations have been made in what settings and use that to guide future adaptations. But the example we sometimes use for this is that, let's say you have some kind of implementation trial where you find not so great results, right? Unless you have a clear sense, though, of what modifications were made to the EBP, what modifications were made to the implementation strategy, it's hard to tell whether your less than stellar results are due to the EBP not being a great fit in the first place, the modifications for the EBP being misguided, whether the implementation strategy wasn't a great fit in this setting, whether the implementation strategy was modified in a way to make it less effective. Again, these are hard questions, and answering them at the very least requires understanding what adaptations or modifications have been made. So this is kind of where we're coming from. And so to start to build this literature, going back to 2013, Shannon Wiltsey-Sturman developed the first framework around kind of documenting modifications to EBPs. And then we published an updated version in 2019 in Implementation Science Credit to Dr. Wiltsey Sturman for being fantastic with acronyms. I believe it was she who came up with the framework for reporting adaptations and modifications to evidence-based interventions, or again, in the terminology we're using today, to evidence-based practices. However, both of those frameworks, right, and a lot of other work conducted by other fabulous researchers is really, as I mentioned, oriented around documenting modifications to EBPs, right? But what about the implementation strategies used to get those EBPs into practice, right? It's not simply a matter of taking the frame and completing it for an implementation strategy, because implementation strategies are fundamentally different from the EBPs that are meant to get them into practice, right? And so therefore we set out to develop essentially a modified version of the frame specifically oriented around implementation strategies, or the frame IS. So I've got the apple and orange here just to show kind of the apples and oranges difference between modifications to EBPs and modifications to the implementation strategies we use to get people to use those EBPs. So moving on then, how did we develop the frame IS? How did we take the frame and turn it into this version that's really oriented around implementation strategies? For those of you who have access to the manuscript, again, which I believe went out with distribution of this, and people can link because it is available open access, we basically tried to go through as rigorous as possible a multi-step process to develop the frame IS to be as applicable and useful as possible. I'm not going to go through these steps in detail, but I did want to really acknowledge this fifth step here, soliciting and integrating stakeholder feedback. Thanks to folks from this group, as well as the Wonder Group, as well as some people who worked with us for one-on-one Think Alouds, basically to help us take the initial version of the frame IS, the initial draft that kind of we had developed just amongst us co-authors, and really turn it into the final version. So some of the feedback that we had received is kind of really pretty strongly the initial version was way too long and had too many items that really didn't seem very applicable or useful, right? So in response to that, we really did want to try to shrink down and kind of cut out the fat, so to speak, cut out the extraneous pieces of the draft frame IS. People also really desired a modular format with guidance around what should be considered core modules of the frame IS that most people would want to complete for their implementation project versus optional modules that might be nice in some settings but aren't really core or central to getting useful data out of the frame IS. So we really tried to take these pieces to heart in developing the final version. So now I'm going to shift and talk about the components of the frame IS. I'm going to try not to go into too much detail on each of these, both because I think that going painstakingly step by step through a model as complicated as the frame IS would probably put everybody to sleep, but also this isn't really a great format for learning those pieces. Again, I direct people to the manuscript if they want to see kind of the whole thing and the components in detail. But long story short, the first of the 4 core modules, the ones that we pretty much recommend completing for most people who are going to use the frame IS to document modifications to their implementation strategies, module 1 really is just kind of a summary module, right? Laying out just in real plain language, hopefully in just a few words each, well, what's the EBP that we're trying to get people to use? What's the implementation strategy that may be modified through the course of our project? Why are we making modifications, the modifications that we have in mind, and why are those modifications made, right? So module 1 is really just meant to give an overall summary of what modifications we're talking about. And we thought this was important because oftentimes people will be making multiple different types of modifications to a given implementation strategy. And we wanted to make sure that in completing the rest of the frame IS, it's easy to keep clear in your mind what modification are we talking about at any given point. So the second core module, what is modified? This is really meant to capture just in broad strokes. Well, are we modifying the content of the implementation strategy, kind of the details of really what we're trying to do to get people to use an EBP? Are we modifying the way that the implementation strategy is evaluated, that second checkbox? Are we modifying the way that implementers are trained? So an example here might be if your implementation strategy is implementation facilitation. I know that we've got folks in VA, right, Joanne Kirchner and Kathy Dollar's group, who have the Implementation Facilitation Training Hub, right? it might be different delivering implementation facilitation trained by that group versus a different type of training for implementation facilitation. So if the training for implementers is changed, you might want to be checking that training box for a modification to your implementation strategy. And finally here, especially relevant for COVID times, other modifications to implementation strategies really might be about the context, right? This is the way the implementation strategy is delivered. So for example, when we think about the format here, right? Are we delivering the implementation strategy in a group versus an individual format? For instance, a good example might be if your implementation strategy is provider training for a particular EBP. If you're changing the format in which the clinicians are being trained, right? That might be a contextual modification, changing the format, right? So again, I'm not going to go into a ton of detail here, but these are the kind of things to think about for Module 2. Are we changing the content? We're changing details of the evaluation or training for the implementation strategy, or are we changing the context in which the implementation strategy is delivered? Moving on to the third core module. Note that this is really only delivered or applicable for content evaluation or training modifications. The reason for that being, if we go back to slide 15, for context modifications, we include the additional checkboxes here for format, setting, personnel, population, or other. But for content evaluation or training modifications, we want to basically then document, well, what specifically is being modified about the implementation strategy. Right, so you can see that these can range from relatively small, like tailoring, tweaking, or refining at the very top, to relatively more fundamental, right? Things like integrating another implementation strategy into the primary implementation strategy we're using. So for example, if your implementation strategy, again, is implementation facilitation, but you're building in a very robust audit and feedback component that is kind of separate from or independent of or built on top of implementation facilitation, then that might be considered a modification that is integrating another strategy, right? So another one I want to draw attention to here is the second to last one, drift from the implementation strategy without returning, right? We certainly want to acknowledge that in some of our implementation projects, things fall by the wayside, right? And so we may want to be able to document that, especially if we can document when the modification occurred, as we'll talk about later. Another thing I want to acknowledge here from Module 3, right? There's an optional addendum over on the right-hand side of the slides here, right? You may also want to, oh, excuse me. Can folks still hear me?
Yes, we can.
Okay, sorry about that. I had a call coming in. I apologize for that disruption. But for this optional component for Module 3, the relationship fidelity or core elements, right? Certainly when it comes to evidence-based practices, a lot of emphasis has been placed on maintaining fidelity to the core components or core functions of an EBP, right? The idea being that you don't want to change those core elements or functions, but some of the adaptable periphery, some of the kind of other things about the EBP may be more amenable to modification, right? Now, in this case, we acknowledge that for implementation strategies, it may not be really clear what exactly those core components or functions are. So you may not want to use this optional addendum to Module 3, but on the other hand, it may be useful to document, do we think that this modification was consistent with kind of the core essence of the implementation strategy? Or do we think that this was a more radical departure? The idea being that by tracking this, we may be able to then reflect on whether, in fact, the things we thought were core functions actually are core functions. If we had an implementation project where the core functions are modified, and yet the implementation strategy was really successful, then maybe we should rethink whether those are in fact core functions of the implementation strategy. So this is kind of Module 3. It's really about kind of the details of what was changed and whether we think that what was changed is still consistent with kind of the core design, core elements, or core functions of the implementation strategy that we're using. I'm going to pause here just to get some water. Moving on then to the last of the core modules, Module 4. we really want to have a sense of what the goal is for the implementation for the change to the implementation strategy. So you can see a bunch of these things listed. I'm not going to go through them in detail, but simply wanted to acknowledge that on the left-hand side here, we basically derived these things from the REAIM framework, as well as Proctor's dimensions, with an additional item about increasing health equity or decreasing disparities in EBP delivery. Certainly, some people might fold health equity or decreasing health disparities into the reach dimension of REAIM, but we really wanted to have this be a separate thing, right? And we acknowledge that if you're doing and documenting an implementation project's modifications using the FRAME-IS, there are certainly changes or modifications for which multiple of these boxes might be applicable. But the goal here is to get at kind of what is the goal of this modification to the implementation strategy. Again, the idea being that if people use this frequently enough, we may be able to determine whether certain goals are better served in terms of making modifications to our implementation strategies. Part 2 is kind of the level of the rationale for the modification. And there are basically different levels here, ranging from very broad level. We're making a change based on broad national mandates, right, which would probably apply across a whole range of different implementation strategies. 2, relatively more specific, right? Are we modifying the implementation strategy specifically to meet the needs of an individual patient, an individual clinician, or an individual implementer or implementation facilitator, right? So this is kind of the end of the core module. So just to summarize what we've talked about so far, the core of the FRAME-IS are these 4 modules: an overall summary module about kind of what we're talking about, what modifications to implementation strategies we're referring to. Module 2 is really about overall what was modified. Module 3 is about the nature of certain types of modifications. And Module 4 is about the goal or rationale for the modifications that are being made to the implementation strategy. We now move on to the 3 optional modules. You can decide whether it makes sense to administer these or kind of use these to track modifications in your own implementation project, right? Part 1, when is the modification initiated? Right. Now, we talk about when the modification is initiated rather than when it's made, because we acknowledge that many modifications to implementation strategies are going to be made throughout the entire course of the implementation, right? If you're changing something about how your implementation strategy is delivered, that may apply across a broad time frame. What we're most interested in here is, when did you decide to make the change, right? And then part 2 is, was it planned, right? Is this a planned or proactive modification, which we would call adaptation? Was it planned, but in some sense reactive, in which case it might be considered a reactive adaptation? Or was it a true modification in the sense that it was unplanned and reactive, made almost completely on the fly, right? Again, the idea here is that if we track this, we can learn a bit more about when it might be appropriate to make unplanned modifications and when it might make sense to stay the course in delivering your implementation strategy. All right. So again, an optional module, but one that might be important for your implementation projects. The next optional module, who participated in the decision to modify. Again, the idea here is that you could use multiple check marks to show how broad the coalition was that settled on this modification, with an optional piece at the bottom to indicate who made the ultimate decision. Again, this could be useful for determining whether, in fact, broad-based modifications, ones that got buy-in from a larger group of people, are in fact more effective, or are there certain circumstances where even if just one person or one group makes the decision to modify, that could still be an effective modification. And finally, the last of the optional modules, how widespread is the modification? That is, for whom or what is the modification made? This is really just getting at the scope question, right? So it could be, again, for more individuals, for groups, or for broader organization or clinic or even network system level. So this is really similar to kind of the module 4 in getting at the rationale, which can occur at multiple levels. But we also want to acknowledge that in this case, we want to get a sense of the scope of the modification that was made to our implementation strategy. So That takes us through the core and optional modules of the FRAME-IS, right? So going through somewhere between 4 and 7 of these would allow completion of the FRAME-IS for your implementation project. But I know that probably up to this point, this feels pretty kind of 50,000-foot view. So I wanted to talk a little bit about example completion of the FRAME-IS, right? So in this case, and thanks to Dr. Maya Barnett for providing this example for the manuscript that we wrote and for the slide set here, but our EBP, Parent-Child Interaction Therapy, or PCIT, right? As you can see here, it's an evidence-based parenting program for young children with disruptive behavior disorders. It's typically delivered via a task-sharing model where you've got professional clinicians partnering with lay health workers. And the lay health workers are really working directly with the families to promote kind of adherence to the protocol and helping them improve skill acquisition. So in this case, the case for our example, the implementation strategy in question was a training program for the lay health workers, right? So in this case, part of the reason that, as you'll see, there was a modification potentially needed is because the implementation strategy, the training program, specifically the lay health worker training program, was originally developed for a Hispanic population in Miami, but was now being rolled out in California, right? So these are the core modules of the FRAME-IS as it pertains to this particular modification to the implementation strategy of the lay health worker training. And as you can see, even though the FRAME-IS is pretty expansive, we really just boiled this down to a few kind of bullet points, hopefully clearly describing how the implementation strategy was modified in this case, right? So you see module 1 there is just making sure that we know what we're talking about as we're going through this, right? The EBP is PCIT. The implementation strategy is this training program for the lay health workers. In this case, right, there was some tailoring in the training content, specifically language, to fit the kind of local population differences, acknowledging that the Hispanic population in Miami is fundamentally different in some ways from the Hispanic population in California. Also worth noting that there was removal of a behavioral coding component of the training, specifically, again, to better fit the needs of the population. And the reason that these changes were made was to improve the appropriateness and feasibility of this modified implementation strategy, this modified training program for the lay health workers. So you can see that these qualified as content and context modifications to the implementation strategy. Specifically, the modifying language was considered a tailoring change to this implementation strategy, and the removal of the behavioral coding component is considered removing or skipping elements of that implementation strategy. We wanted to acknowledge that we aren't really sure whether these should be considered core components of the training program of the implementation strategy. And the goal, again, in a little bit more detail, is about increasing acceptability, appropriateness, and feasibility of the implementation effort. And this is basically done at the practitioner and patient level, again, to address some differences here in the population of predominantly Mexican descent in California. So long story short, if there's one takeaway from this slide, it's that this is an example completion of the core modules of how this implementation strategy was modified based on the FRAME-IS for documentation. So our hope is that this gives a relatively easy to digest kind of version that easily communicates what was changed for this implementation strategy for this particular project. Going through a bit more briefly, for the optional modules, these changes were made in the pre-implementation or planning phase. These are considered planned or proactive, like before rolling this out in California is when these changes were made to this implementation strategy. While a lot of different people did participate in the decision to modify, ultimately it was researchers who kind of settled on the final version and made these changes. And how widespread was the modification? Well, it applied to the entire California rollout. So that's the kind of scope or widespreadness of this modification, or really adaptation of this implementation strategy of this lay health worker training program. So I hope that that reasonably communicates kind of how this could be completed for an example. Moving on then, in terms of future directions, right? There's still a bunch of unknowns here, right? We don't want to pretend like this is settled law, right? This is a new implementation strategy, modification documentation framework that has started to be used, but there are a lot of questions to answer, right? How frequently should this be completed? Can we simply look back at the end of an implementation project and complete the frame IS for all modifications that were made throughout? Well, we don't really know yet. I think my gut reaction would be that if it's a really long implementation project, you might want to look at the frame IS periodically and just see whether there are new modifications kind of coming online. We're also not really clear exactly who should be completing this or how best to limit the documentation burden. Again, we tried to make it relatively digestible by having this modular format and kind of flagging what we consider to be the core modules. Is it more useful for certain implementation strategies than others, right? I've referenced implementation facilitation as an example of an implementation strategy that can certainly be modified. Now, one of the challenges for that is that by its very nature, implementation facilitation is meant to be adaptable. It's meant to not be delivered in the same exact way in two different projects. It remains to be seen whether the frame IS is going to be useful or more or less useful for those more complex, adaptable, modular implementation strategies, as opposed to kind of more clearly defined and encapsulated implementation strategies. And most importantly, the patterns and implementation outcomes emerge, right? Again, our underlying assumption here is that tracking this stuff will be helpful for hopefully unlocking the black box about which implementation projects really work really well versus crash and burn, right? We think that tracking this will help hopefully differentiate which modifications are most useful to enhance overall outcomes of our implementation projects, but that's an empirical question. And we also want to acknowledge that the frame IS is currently being piloted in a relatively robust study here. Thanks to Cassidy Guttner, one of the co-authors, for kind of helping incorporate the frame IS into this ongoing project. So hopefully as that project wraps up, we'll have some additional information relevant to these other questions regarding the applicability and utility of the frame IS. Having said that, in terms of wrap up and summary here, right, there is broad agreement in the field that modifications both to EBPs and to the implementation strategies we use to get them into use are important for healthcare innovations to stick in real-world clinical practice. We think that there's a need for careful documentation of those modifications, because without that documentation, it'll be hard to kind of exactly get the mechanisms by which these implementation strategies are working. The frame IS is designed to do exactly that. It's designed to track these modifications that we think may be useful. And again, our overall goal here is not just to develop a cool model or framework, but we hope it helps us really understand how we can maximize health outcomes and address inequities or health disparities in our implementation work and ultimately in the healthcare that we deliver. So I wanted to thank everybody for your time and attention. I do, again, have the linked articles in the slide set. There's also a link here to Dr. Wiltsey Sturman's FAST Lab. The resources section of that website has a ton of extra information in detail. And if you'd like to use the frame IS for an upcoming project, I mean, we'd love that, right? So I've got my email address linked here as well as my Twitter handle. And I believe that takes me through the presentation. So thank you, everybody, and I'm happy to hopefully address some questions here. I can't see the chat right now. Christine, I don't know if you want me to leave my slides up or if I should stop sharing. What makes sense to you?
Why don't we leave the slides up, and then if anyone, sometimes we get questions that you want to refer back to a slide, you'll have that available.
Sounds good.
Okay.
Thank you, Heidi.
So
That's perfect.
We do have a few pending questions here for the audience. If you have a question, we do have plenty of time for questions. Please send those in using the Q&A screen. The first question that we have here, there seems to be an underlying assumption, perhaps that only one implementation strategy would be utilized to facilitate the implementation of an intervention. Is this true? And do you have an opinion about an effective number of implementation strategies to use for an EBP?
Yeah, that's a great question. And, you know, I don't have a hard and fast answer. I mean, I think as we want to acknowledge here, oftentimes implementation strategies do get added on top of others, right? So if your situation is simply that you are going in from the outset, combining multiple different implementation strategies, then you may just want to define that, right there in module 1, right? That our baseline implementation strategy is actually a combination of 2, and then we'll document modifications beyond that. In contrast, it may make more sense to frame this as we're starting with a baseline implementation strategy, and then one modification we are making is integrating components from other implementation strategies as a modification. My gut tells me that which of those 2 views you take will depend on whether one is really considered the primary to which you're adding, versus if they're really kind of co-equal implementation strategies from which you're starting. Either way, I think that the most important thing is to just clearly communicate that as you're writing things up. Again, I think sometimes it's going to take more than one implementation strategy, and that's fine. When it comes to the use of the frame IS, I think it really comes down to just clearly delineating how you're viewing that so that you don't end up confusing yourself or your reader about what's a modification to that 2 implementation strategy package versus whether one of those is really modifying the other.
Great, thank you. The person sent in an additionally, this seems to assume discrete implementation strategies being used rather than comprehensive implementation strategies. Is this a correct assumption?
Yeah, that's a great question, and I wouldn't say that that assumption is kind of fully settled, right? We suspect that this may be more useful for relatively more discrete implementation strategies. Having said that, you can use the frame IS even for relatively complex multi-component implementation strategies. For example, if you've got a very complex one like implementation facilitation, but you're switching from kind of face-to-face implementation to something remote for COVID-19, you could still document that using the frame IS as a context modification of implementation facilitation. But having said that, I think a fundamental assumption of this is that you are starting with something that at least is clearly defined, because documenting modifications to something that's so fluid that every modification can be subsumed under it would be a bit of a hard sell. So I think, honestly, we don't necessarily know yet exactly how applicable this is to the complete universe of implementation strategies that are out there. And certainly we want to acknowledge that documentation is going to be harder for some than for others.
Great, thank you. The next question here, can this be used as a retrospective set of activities rather than prospective activities?
Yeah, I think probably the answer is yes, it can be done retrospectively. I think it remains to be seen whether that retrospective recall, leaves something out. But certainly just thinking of the example that we talk about in the manuscript of PCIT, I believe that Dr. Barnett went through and essentially completed the frame IS retrospectively. I don't think that this was something where she was documenting modifications throughout. So if I can scroll back here to PCIT, right here, right? So what was done here under example completion was done retrospectively. Again, I think that kind of retrospective completion is probably going to be more effective when you've got, a really clearly delineated set of modifications that were made at a really discrete time, right? Like the examples that were included here. If the modifications you're trying to track are the more kind of emergent modifications, the reactive modifications that may change from month to month or even week to week, that might require more periodic data collection throughout the implementation project rather than simply a retrospective look back after 3 or 6 months of implementation. So I guess tying it all together remains to be seen, but I don't think that doing this retrospectively is necessarily a bad idea.
Great, thank you. The next question here, this is so interesting, thank you. 2 questions. Number 1, if you do something to facilitate the implementation of a practice that is not evidence-based, but is obviously beneficial, such as increasing communication among staff in an emergency department, would you count that as an implementation strategy? And number 2, can you say more about a strategy such as audit and feedback as a standalone strategy versus integrated into another strategy such as facilitation?
Sure. Can you go back and read the first question again?
Of course, if you do something to facilitate the implementation of a practice that is not evidence-based, but is obviously beneficial, such as increase in communication among staff in an emergency department, would you count that as an implementation strategy?
That is a good question. I think there are multiple ways to conceptualize that particular approach. So I guess from that perspective, is the increased communication, if the goal of the increased communication is to get the emergency department staff to do some kind of evidence-based practice more, then I guess I would consider that an implementation strategy. So in that case, communication training is the implementation strategy with the ultimate goal of increasing uptake of some kind of evidence-based practice in that setting. I think you could conceptualize it that way, but don't quote me on that. Again, I'm going to go back to Jeff Curran's work and just say that it's really important to kind of just clearly lay out, to the extent possible, what's the specific EBP you're trying to get into play, and then what are the specific implementation strategies. And then if we accept that premise, if we accept the idea that some kind of communication training is an implementation strategy, then if you change the way you are training people to communicate, that might be considered a modification to that implementation strategy. Even if the implementation strategy itself, namely the communication training, doesn't have a robust separate evidence base. But again, I'd be happy to talk about that more offline too. That's a hard one to kind of really lay out, kind of just verbally visualizing it in my mind. And Heidi, what was the second question?
The second question, can you say more about when a strategy such as audit and feedback is a standalone strategy versus integrated into another strategy such as facilitation?
Yeah, I think the key delineation there would just be, is there another strategy going on at the same time? I mean, the way that at least I've conceptualized it is that audit and feedback is in and of itself an implementation strategy. I think it's one of the 73 ERIC strategies that's listed. And so if you're doing audit and feedback as like, that's the thing you're doing to get these providers to change their behavior, then I guess that would be standalone. If, in contrast, the audit and feedback is being delivered alongside a bunch of other work from an implementation facilitator working with some kind of champion or internal facilitator at the site, in addition to the audit and feedback, that is, if the audit and feedback is just one thing that's going on amongst a broader suite of things being done to help get those providers to change their behavior, then I think that could be considered a modification or an add-on. But again, a lot of it depends on the timing, right? Is it that we're doing implementation facilitation and then we're building in a robust audit and feedback component? Or are we doing audit and feedback and then realizing that it's not working very well and we're adding on some additional facilitation support? In the latter case, I would think that the modification would be adding some components of implementation facilitation to a baseline of audit and feedback rather than the reverse. I hope that's helpful.
Thank you. Next question here. What are the principles to separate the core of an intervention from its adaptable periphery, using CFIR terminology?
Oh my goodness, that is, I'm going to acknowledge that is a really, really hard issue, and that's one that other people have published a lot more stuff on than I have. I think about Brian Mittman and his work alongside other really, really good researchers related to kind of core functions versus core elements. I honestly don't have a clear sense for evidence-based practices. A lot of it really gets down to what do we think are the mechanisms by which this EBP is really improving clinical care, improving the outcomes of our patients. When it comes to implementation strategies, I think what's core is considered what are the things that are fundamental to actually getting providers to change their behavior or patients to change their behavior so that this EBP is actually used more, basically. So I'm sorry I kind of stumbled through that answer, but the short answer is that's a really tough question, and I defer to other people in the field who've done a lot better research on that than I have. For our purposes here, it's really left up to the person completing the frame IS to determine whether it makes sense to try to delineate whether something was really changing the essence of what the implementation strategy is versus kind of changing the kind of little pieces that are changing around that.
Great, thank you. The next question here, how would you ideally analyze this data that you receive on modifications using the frame IS modules?
Yeah, that's a great question. I think one way to do it, if you have, let's say, an implementation project that's a multi-site implementation project, and you have kind of a robust picture of how implementation proceeded at each site, certainly might be useful to notice things like which modifications were made at the sites that did the best. In contrast, are there modifications that were made at sites that didn't do so well? Now, there may be a third variable problem there in that certainly one of the reasons people may modify their implementation strategies is because there are contextual challenges or other big barriers at the site that need to be overcome. And so just because a certain modification was made at a certain site and that site's implementation didn't go so well, that doesn't mean you can necessarily attribute the lack of success to the modification. But at the very least, if you have a multi-site trial and you're tracking modifications at each site individually, you can use that as data to reflect on maybe which modifications seemed to be effective versus not. And you can then use that moving forward at other sites and implementation across those sites. So that's, I think, the big one. Again, that's the holy grail, the one where you use this to actually reflect on which modifications were most successful in which settings.
Great, thank you. The next question here, would you say more about your use of the term planning? To me, planning is forward-looking, and so the idea of reactive planning sounds like an oxymoron. But I think it's meant to describe when modifications are made as part of a learning process, that is, in response to things that are learned in the process of implementation. Is that correct?
I like the latter half of that question so much, I'm just going to say yes. I think that's a great example of a planned but reactive modification, right? So there's some kind of issue that comes up in the middle of an implementation project, and it demands some kind of reaction. But even though the time frame is tight, the implementation team gets together and really plans through, here is what we want to do in response to this unforeseen challenge. I think that would be a good example of a reactive yet planned modification.
Great, thank you. Next question here. Is there a simple Excel type template for Frame IS? If so, how can we get a hold of it?
Yeah, that's a great question. I think that on Shannon's end, that may be in development. And I believe as well for the piloting of the Frame IS, Dr. Guttner as well may have an example of that. So if you want to email me or check out the FastLab website, we can certainly try to connect you to whatever resources we have to make this as completable as possible.
Great, thank you. Just to interrupt questions for a second, I see we got a request in for a slide deck for today's presentation. The link to the slide deck was included in the reminder that was sent out this morning, so just refer back to that email. You should have received it 2 to 3 hours before the session. If you cannot find that reminder, we are recording today's call and we will send that link out as soon as that is posted. You will also be able to access the handouts from that link. Okay, the next question here. Do you have any recommendations on how to best collect adaptation information from providers or sites that is not too burdensome? For example, we are using Frame to ask site points of contact these questions at various time points.
Mm-hmm. I think that my gut reaction is that, certainly in that case, if you're looking to minimize burden, I would probably not go with modules 5, 6, and 7. It sounds like that may be too much of a documentation burden. Other options include, well, first, I think thinking about who should be the one completing the frame IS, right? If there is in fact somebody external to the sites, like an implementation facilitator or a trainer, it may be that they are well positioned to document the changes made to the implementation strategy, whereas the frontline clinicians may be better positioned to document changes to the EBP itself because that's what they're delivering. So I think carefully about whether there's somebody other than frontline staff who can document changes made to the implementation strategy itself. And it may very well be that you look at the core modules and you say, you know what, we need to limit the number of checkboxes. We think that these particular types of modifications to the implementation strategy just aren't very likely. And so maybe we don't include those in administering our modules. So hopefully retaining some of the checkboxes as originally intended in the frame IS. But again, a lot of this is really up to the field. A lot of this is really up to you folks as to what's useful about this. We aim to be comprehensive with the frame IS, and of course we'd love it if it would be used as closely to its kind of distribution version. But we acknowledge that if the choice is between overburdening people or kind of trimming down just to what you think is happening, then that may be better than nothing at all.
Great, thank you. The next question here, do you believe that we really have enough descriptive information about the ERIC implementation strategies to know how to utilize these strategies?
I guess I know that ERIC, there are a lot of different strategies. My understanding is that kind of science of which implementation
Chris, I think we've lost your audio a little bit.
Oh, I'm sorry. Can you hear me now?
There we go. Yep.
Okay, sorry about that. That's what I get for walking around while I answer this. I was just saying that I think that in order to kind of bypass that really thorny challenge, that's why for the frame IS, we kind of start right with module 1 is simply acknowledging, okay, what is the implementation strategy you're using, right? And whether that's something that's listed under ERIC or another implementation strategy that incorporates multiple of the ERIC components. That's kind of the view that we take for the frame IS because we acknowledge that, those ERIC strategies, there are a lot of them, and in many cases, multiple of those are being used even in the context of one implementation project.
Great, thank you. The next question here. I'm curious about how you may go about establishing reliability and validity of this tool within a given trial. I'm thinking about the different strategies we use to establish reliability to blinded outcomes assessors for quantitative research and reliability of coding for qualitative research.
Yeah, that's a great question. And I think not to punt too much on that, but I think to a certain extent that is really going to be dependent on future work, right? Could you have, for instance, each of two kind of implementation trainers or champions each independently complete the frame IS based on the work that they kind of collaboratively did with the site? I would think that might be one way to really establish the reliability piece. But certainly to a certain extent, at least the way that the frame IS has been developed so far, that's an open question about kind of how reliable people are and how valid their ratings are, given that people may, for example, not want to admit that they've changed the implementation strategy. So another thing might be to combine completion of the frame IS with things like time tracking. I know for some of our implementation projects, we have implementers kind of periodically track the time they spend on what activities. And it may very well be that that could be then put next to the frame IS to look at whether there seems to be some kind of concordance between the kind of line by line of what people said they were doing and what overall kind of modifications they note making to the implementation strategy. But I want to acknowledge that that's kind of an open field at this point.
Great, thank you. The next question here, can you provide an example of how to explicitly consider health equity in Module 4 based on your PCIT example?
Sure. So going back to Module 4, we got PCIT. Here we go. What is the goal and what is the level of rationale of the modification? So I think in this case, right, looking at the modification to Module 4, so specifically kind of changing the language was increasing the kind of aim to increasing the appropriateness. So it may very well be that one could consider those modifications to the language as a way of increasing health equity or decreasing disparities in EBP delivery, in the sense that perhaps the changed language in this lay health worker training is going to be a better fit for the population in question. Also thinking about removing the behavioral coding component. My understanding is that that was undertaken really just to be a better fit with the population, even if it wasn't necessarily squarely aimed at kind of decreasing health disparities. So I do think that the modifications that we talked about in Module 4 for the PCIT, I mean, I think the primary kind of goal was really to increase the acceptability, appropriateness, and feasibility. But it might very well be that another check mark there should have gone into increasing health equity or decreasing disparities in the EBP delivery, given just the population then being served ultimately with the patient population in California. So I don't know if that answers the question, but certainly acknowledge that it might well have been a good fit to kind of include an additional check mark for that modification.
Great, thank you. The next question here, how important is it to track adaptations to the intervention being implemented in addition to adaptations to the implementation strategy? Seems that those could be very different from each other.
Mm-hmm. Yeah, I think my gut reaction is that it is, I think that's a great point, and I think it's very important to track those modifications as well. You know, the idea being that if you don't track modifications to the EBP, right, then you'll be uncertain at the end of the day. Well, is it that this implementation strategy was a bad fit? Is it that these modifications were a bad fit? Or is it that the frontline clinicians or the administrators or the clinical leaders were changing the EBP in a way that didn't necessarily lead to good outcomes, right? So when it comes to this kind of tracking, I think that is a great argument in favor of using the frame alongside the frame IS, so that if you get good or bad outcomes, you kind of have a sense of what was going on, and there's not kind of a gap in your understanding that might be responsible for those good or those bad outcomes. And maybe
Great.
just acknowledging it's near the top of the hour. I know I have a patient at the top of the hour as well. Maybe one more question, if that's okay, Heidi?
You know, actually, we only have one more question, so that works out really nicely. Perfect. Our question here, the part in Module 2 on how implementers are trained can be confusing in practice. Many stakeholders think of implementers as, for example, the clinicians doing the thing with or for patients, rather than the people helping the clinicians do the thing. The fact that training itself can be an implementation strategy may add to the confusion. Thoughts? Chris, we're not able to hear you.
Oh, can you hear me now?
We can, yes.
Okay, sorry about that. Just my gut reaction is yes, that is a confusing distinction. We go into a bit more detail in the paper, and especially the supplemental material, the additional material from the paper, which has a little bit of extra detail for each module. But yes, we certainly want to acknowledge that if the frontline clinicians delivering the EBP are also considered the ones kind of doing the implementation, that can create a lot of really hard distinctions to draw. And so I think my overall feedback there is to make sure that you're clearly delineating who's in what role. And to the extent possible, really kind of making a clear distinction for those frontline staff. Are they really the implementers? Are they the people helping get the thing done? Or are they the people doing the thing, if that makes sense?
Makes sense. And that is all of our questions. We're at the top of the hour here. I know that you need to run to a patient. If you need to run, I'm just going to let Christine wrap things up and we will close the session out. Thank you so much, Dr.
Thank you,
Miller.
everybody, for your time and attention. Again, do reach out if you have questions. And yeah, I'm going to sign off, but I really appreciate it.
Thank you. Christine, do you have any closing remarks?
Just thank you so much, Heidi. Thank you to the audience for their wonderful questions. And of course, thank you to Dr. Miller. We'll be back. There are no sessions in August, but we'll be back in September with a session with Dr. Russ Glasgow and Dr. Borska Rabin. So please be sure to tune in for that. And thank you all so much. Have a good afternoon.